Welcome to My Dental Key and Colgate's Oral Health Promotion and Disease Prevention module covering fluoride. The goal of this module is to enable oral health professionals to educate patients on the evidence of fluoride and demonstrate the ability to apply fluoride to patients. In this module, you will learn to demonstrate knowledge and understanding of the evidence-based dentistry recommendations for the use of fluoride in caries prevention. Understand the mechanism of action of fluoride, identify which patients would benefit from systemic fluoride supplementation, and list and perform the steps of applying fluoride varnish to a patient's dentition. The history of fluoride starts with the research on fluoride's impact of oral health in 1901 when Dr. McKay noticed brown staining on teeth that was resistant to dental caries. He called it the Colorado brown stain. With the help of a chemist, H.V. Churchill, Dr. McKay identified that the water had natural fluoride that molted the teeth but reduced caries incidence. Following this, in 1945, Grand Rapids, Michigan was the first city in the world to establish community water fluoridation. They completed a 15-year study that demonstrated that fluoridation of public water effectively reduces the dental caries burden. Following this, fluoride was established as a safe and effective preventative measure for caries. Leading U.S. research and health organizations, including the National Institute of Health, National Institute of Dental and Craniofacial Research, and the U.S. Surgeon General, collaborated to establish and implement safe levels of fluoride in community drinking water. The Centers for Disease Control and Prevention of the United States listed community water fluoridation as one of the greatest public health achievements of the 20th century. Following the success of community water fluoridation, fluoride was introduced as an active ingredient into dental dentifrices in the 1950s. When given at the correct dose and concentration, fluoride serves as an additional preventative measure against dental caries. Since its arrival in the dental office, applicational fluoride has been made in available forms such as gels, foams, and varnishes. Fluoride is also an ingredient in cements and restorative materials. Scientific data supports the use of fluoride for prevention of tooth decay. Recently, a movement against fluoride has mobilized. Keep watching to learn about the science-based safety and efficacy of fluoride use. Dental caries result from the production of acidic byproducts by cariogenic bacteria housed in the dental plaque. Cariogenic bacteria metabolize carbohydrate substrates from the diet into lactic acid, which in turn decreases the pH of the oral cavity, favoring enamel demineralization and ultimately loss of tooth structure. Fluoride ions accumulate in the dental plaque, thereby contacting the tooth structure. Fluoride works to prevent dental caries via the following mechanisms. It inhibits the demineralization of enamel under acidic conditions by reducing enamel's acid solubility and by raising the salivary pH. It also enhances remineralization of enamel in the early stage carious lesions by replacing hydroxyl radicals of hydroxyapatite crystals in enamel, producing fluoroapatite, which is less soluble in catabolic acids produced by oral bacteria. Fluoride also reduces the cariogenic potential of bacterial plaque by disrupting bacterial enzymatic pathways via glycolytic enzyme inhibition and alcoholic fermentation, and lysing bacterial cell membranes by enhancing membrane permeability. Fluoride can be delivered systemically or topically. Systemic fluoride is consumed via food and water. Dietary fluoride can be either naturally occurring or reinforced, such as community water fluoridation measures, reinforced fluoridated salt, milk, juice, and other foods shown here. Whereas fluoridated water is more common in the United States, other countries use fluoridated salt as a community prevention measure. The systemic delivery of fluoride can be absorbed into the bloodstream and then incorporated into the developing teeth. These systemic delivery methods of fluoride can also have a topical effect. When the fluoride is in contact with teeth, it can have the benefits as discussed in the mechanism of action of fluoride earlier. The CDC recommends that 0.7 milligrams per liter or 0.7 ppm is the optimal water fluoridation level. The World Health Organization recommends that drinking water quality of fluoride be 1.5 milligrams per liter, but emphasizes the importance of setting national standards for fluoride that take into account the naturally occurring fluoride concentrations, volume of water intake, and the intake from other sources, such as food. Topical delivery of fluoride can come from toothpaste, mouthwashes, and mouth rinses, or professionally applied fluoride varnishes, foams, and gels. Standard over-the-counter toothpaste has effective fluoride concentration ranging from 1,000 ppm to 1,500 ppm. The desired amount of fluoride in toothpaste depends on age, carries risk, and natural fluoride exposure. For patients who have less exposure to fluoride, prescription toothpaste can be prescribed at 0.5% or 5,000 ppm. Check out our toothbrushing module for more information on brushing and toothpaste. Fluoridated mouthwashes have been shown to improve caries prevention in non-fluoridated communities. Professionally applied fluoride varnish has become the most widely used office-applied topical fluoride, but gels and foams are still in use. Fluoride varnish is sold as a 5% sodium fluoride varnish. Fluoride acidulated phosphate fluoride, APF, foam is a fluoride concentration of 12,300 ppm, or 1.23%. Fluoride acidulated phosphate fluoride, APF gels range from 0.6 to 1.23%. All of these can be utilized in the dental office. Use your clinical judgment to determine which is best for your patient. Fluoride application is beneficial when patients do not have adequate exposure to fluoride through diet, fluoridated water exposure, or toothpaste. It is important for oral health professionals to ask patients about their fluoride exposure and to make clinical decisions about fluoride treatment. Supplemental fluoride application is related to individual caries risk, as well as individual consumption and exposure, and the stage of tooth development. Professional fluoride application is recommended at least 2 times per year, but can be applied between 1 to 4 times a year, depending on caries risk. Oral health professionals can use patients' health history to indicate the best and optimal fluoride supplementation on a per-patient basis. Topical fluoride application is not contraindicated in adults, but is often not covered by insurance, thus limiting its utilization. Application of fluoride varnish is recommended for children under 6 years of age every 3 to 6 months by the United States Preventative Services Task Force. As an effective public health measure, other healthcare providers, such as pediatricians, physicians, and nurses, are able to apply fluoride. Professional fluoride products should only be applied by or under the direction of a dentist, physician, or healthcare provider who is familiar with the patient's oral health, fluoride exposure, and caries risk assessment. Although there are no confirmed allergic reactions to fluoride, fluoride varnish application is contraindicated when individuals are allergic to components of the varnish. Fluoride varnish should not be applied near areas of ulcerative gingivitis or stomatitis, as it may worsen symptoms. When utilized in proper concentrations, fluoride has limited associated risks. Dental fluorosis is the most common side effect of systemic fluoride overexposure and results in intrinsic staining of the teeth. Chronic fluoride toxicity of levels greater than 1.5 ppm are associated with dental fluorosis, especially in children up to age 8 years old when their teeth are developing. Although fluoride toxicity is rare, a dose of 5 mg of fluoride per kilogram of body mass can result in acute fluoride toxicity. Initial signs of fluoride toxicity begin with gastric symptoms and may progress to cardiac or neurological signs. Initial treatment includes decreasing fluoride absorption in the GI system by administering a calcium-based solution. Patients with concern should seek medical attention or call the Poison Control Center. When talking to patients about fluoride, use evidence-based dentistry to enforce the safety and efficacy of its use. Talk to patients about fluoridated water and dentifrices. Many dental organizations support the use of fluoride in preventative treatments and as part of daily care. Refer to scientific literature when answering patient questions about fluoride prior to its application. In this part of the video, we will demonstrate how to apply topical fluoride varnish. Topical fluoride varnish is formulated to be 5% sodium fluoride, or 22,600 ppm. Start by assembling the proper armamentarium, which includes the fluoride and applicator, and the optional gauze and mouth prop. In the clinical setting, make sure that you and the patient are wearing proper PPE. Proper PPE includes safety glasses for both you and the patient, a patient bib, and gloves. You may now open the fluoride packaging. Start by removing gross plaque from the teeth using hand instruments, a toothbrush, or a clean gauze. Optionally, to dry the teeth, you can use a gauze, or you can use the air-water syringe. Use the applicator to mix and scoop the fluoride varnish out of the packaging. Lightly brush the fluoride varnish to create a thin layer on all surfaces of the teeth using the applicator. Apply the fluoride in a systematic manner. Here, we start in the upper right, move to the upper left, and then continue from the lower left to the lower right. Ensure that you brush the fluoride varnish onto the buccal, occlusal, and lingual surfaces, moving the cheeks and tongue as needed to gain access to the surfaces. Use the applicator to deliver fluoride interproximally by inserting the applicator between the teeth below the contact area. Optionally, you may apply fluoride varnish to floss and floss interproximally. You may optionally wipe the patient's tongue with gauze to remove any excess fluoride. Following the fluoride application, allow the patient to expectorate. Do not allow the patient to rinse or use the saliva ejector. Removing fluoride via saliva ejector will clog the line. Following fluoride application, give the post-application instructions. Instruct the patient to eat only soft foods for 2 hours after the treatment or follow the manufacturer's instructions. Avoid hot, crunchy, or sticky foods and beverages. This will allow the fluoride to remain on the teeth longer, as these hot food and beverages, or crunchy foods like chips, can scratch off and wear away the fluoride. Instruct the patient to resume their normal oral hygiene routine and brushing the following day. This will allow the fluoride varnish to stay in contact with the teeth as long as possible. Fluoride is a naturally occurring mineral that, when utilized in proper amounts, prevents tooth decay. Community water fluoridation is a common public health measure used in the United States and around the world to reduce the oral disease burden. As an oral healthcare clinician or adjacent healthcare professional, we must assess caries risk among patients in order to tailor fluoride recommendations on a patient-by-patient basis. You have completed My Dental Key and Colgate's Oral Health Promotion and Prevention module on fluoride. Check out our other modules on brushing and flossing to help promote oral health. Thanks for learning with us!